Okay, so we were doing hematology, and I think we were about to start off microcytic anemias, but let's just do a quick run through of the most commons. So we said the most common overall cause of anemia itself is iron deficiency. If we have an anemia that's in an alcoholic and they showed an increased MCV, we're talking about folate deficiency. If we're talking about anemia that occurs in vegans, it's going to be B12 deficiency. Anemia in women less than 35 is going to be iron deficiency. Why is it going to be iron deficiency? Because women have menorrhagia, okay? And if it's a man less than 50 years old, we said it's most probably due to an ulcer, a bleeding ulcer. But once men and women both get over the age of 50, we're thinking about colon cancer. Okay, so less than 35 women, menses. Less than 50 in men, ulcers. But over 50 in both men and women is colon cancer. We know pregnancy depletes folate. That's why we have to supplement them with folate. So if they get an anemia in pregnancy, it's going to be a folate deficiency, or if it's a microcytic anemia, they also become iron depleted. They can also have an iron deficiency because of the dilutional effect. If it's an anemia that occurs in a newborn, this is going to be secondary to a bleeding Meckel's diverticulum, okay? So these are most commons. If you see these on your test, you're going to be able to choose these kind of fast. So you got to memorize these most commons. Anemia in an African American, remember, we said that this is going to be what? Iron deficiency anemia. Because in African Americans, you don't want to go for sickle cell because it's much easier to be iron deficient than it is to have sickle cell. SLE or any other autoimmune diseases, you're going to be thinking about autoimmune hemolytic anemia, and we're going to talk about the workup of that when we get into that. Drugs that can cause G6PD. We talked about permaquin. We talked about dapsone. Drugs that can cause folate deficiency. We talked about methotrexate, which inhibits dihydrofolate reductase. We talked about oral contraceptive pills, phenytoin, trimethoprim, sulfamethoxazole, TMP-SMX, etc. Okay. So now let's get a little bit more specific and let's talk about your microcytic anemias. So microcytic anemias, how are we going to define this? Do you know what MCV we're looking for? So we're going to be looking for an MCV of less than 80. Okay? And of the microcytic anemias, we know that iron deficiency anemia is the most common. Other causes of microcytic anemias include anemia of chronic disease. Thalassemias are also microcytic anemias, as well as sideroblastic. Sideroblastic is when you have an iron overload in the cell, and it's actually the least common of these microcytic anemias. Macrocytic anemias are when you have an MCV of over 100. So anything between this 80 and 100 is a normocytic, okay? And your most common is going to be folate deficiency, and you commonly see this in alcoholics, and B12 deficiency as well. But remember what we said about B12 deficiency. You don't see this in alcoholics because you have a 6-month supply of B12 stored in the liver. So B12 deficiency is usually going to be secondary to malabsorption or parasites like Diphyllobathrium notlatum, or if someone gets a terminal ileal resection, we know that B12 is absorbed in the terminal ileum, so that can be a cause of B12 deficiency. But folate is commonly seen in alcoholics, okay, and also in those other cases, phenytoin, methotrexate, oral contraceptive pills, pregnancy, etc. Okay, all the other things that can deplete your folate. Now we talked about the corrected reticulocyte count. And we said that anytime that they give a reticulocyte count, you have to correct for that reticulocyte count. And the formula that we used for that was that we took the patient's hematocrit we divided it by 45, and then we multiplied that by the reticulocyte count. So if they give you a reticulocyte count, you always have to do this formula to get a corrected reticulocyte count. And then based on that number, we're going to see whether there's a good response to the anemia or there's a poor response to the anemia. So if it's over 3% is your number, that's a good response. What are the different things that give you a good response? What we said was autoimmune hemolytic anemia, congenital spherocytosis, blood loss more than 1 week, because we know that it's going to take a minimum of 1 week for your marrow to synthesize the RBCs and then bring them to the blood. A corrected reticulocyte count of less than 2% is considered a poor response. It's going to be one of the extremes on the exam. That means there's an ineffective erythropoiesis going on. What does that mean, ineffective erythropoiesis? Something's going on in the bone marrow. Something's wrong with the bone marrow. So iron deficiency anemia. There's not enough iron to synthesize hemoglobin. Anemia of chronic disease, aplastic anemia, B12 folate. These are all examples of a poor response to where something's actually wrong in the bone marrow. Okay. Now, when we're talking about a corrected reticulocyte count, anything less than 2%, something that's very common, that's less than 2% is acute blood loss. Because acute blood loss, we know there's not enough time for erythropoiesis to go on, okay? So acute blood loss is anything less than 5 to 7 days. And then we talked about early iron deficiency anemia, or early iron deficiency. We talked about anemia of chronic disease, aplastic anemia, even renal disease, okay? And then when we said a good response is over 3%, corrected retic count over 3%, we're going to split this up into both intrinsic and extrinsic red blood cell defects. Intrinsic defects, you can remember the mnemonic MAD. So you have membrane defects. Membrane defects mean what? Congenital spherocytosis. It's a membrane defect. Congenital spherocytosis includes deficiency in what? Spectrin, we know. But what do they love? Ankyrin. Don't forget this one, okay? And there's a membrane type of defect that's going on. Let's do an integration real quick. What vitamin deficiency can cause hemolysis because of a membrane defect? You remember vitamin E. And how do you remember that? Think about the erythrocyte. Erythrocyte, that's an erythrocyte, and vitamin E is necessary for the membrane integrity of the erythrocyte. If you have a vitamin E deficiency, you're going to get hemolysis, okay? So a blood problem that can cause a membrane defect is a vitamin E deficiency. Another intrinsic RBC defect. Intrinsic, something wrong with intrinsic RBC is abnormal hemoglobin. And what's an abnormal hemoglobin example? Sickle cell and all the different variants. And then you got deficient enzymes. And the deficient enzymes we know about are G6PD deficiency, pyruvate kinase deficiency, etc. And then we got extrinsic red blood cell defects. And this is also going to have a corrected reticulocyte count of over 3%. And an example of that would be autoimmune hemolytic anemia. Another example would be microangiopathic hemolytic anemia. What kind of patients do we see this in? Patients with aortic stenosis, etc. Patients with TTP can also get it. And blood loss of greater than 1 week. So intrinsic hemolytic anemia, something's wrong with the red blood cells. Extrinsic means something outside the red blood cell is destroying this cell, okay? So let's talk about iron deficiency anemia. So we know in iron deficiency anemia that we have a decreased heme synthesis. A decrease in your heme synthesis. So basically, what did I say? As a rule of thumb, every time that you have a decrease in your iron stores, and your iron stores are known as ferritin, you are going to have an increase in your TIBC. Anytime you have a decrease in your iron stores, you're going to have an increase in your TIBC. So a decrease in your iron stores are going to cause your liver to synthesize more transferrin. And when you have an increase in your synthesis of transferrin, that's your binding protein, so then you're going to have an increase in your TIBC. So this is going to correlate to your TIBC. Your most common cause of iron deficiency anemia is going to be bleeding. It's usually going to be some type of GI bleeding that's going on, okay? And if you're having it in newborn, what do we say? It's going to be most probably a Meckel's. Pregnancy. We have to know that lactation depletes iron. So in pregnancy, you can have an iron deficiency anemia as well. Females less than 50, what do we say? Menorrhagia. Males over 50, we said ulcers. And both males and females over 50, we're going to think colon cancer. A bleed due to a colon cancer. What's the only one we have to know that has an increase in your RDW? That's going to be iron deficiency anemia, okay? The one we're talking about right now. If the patient has some type of malabsorption, they come in with an esophageal web, and they have achlorhydria, and they have spoon-like nails. This we know is Plummer-Vinson syndrome. My treatment is going to be ferrous sulfate. And you got to remember, we can also give ferrous gluconate. We got to remember our findings that we're going to look for is a decreased iron, increase in your TIBC, decrease in your percent saturation, decrease in serum ferritin, and the only one that has an increase in your RDW, your red cell distribution width. Okay? So to review, we said iron deficiency anemia, you have a decrease in your iron stores, you have an increase in your liver synthesis of transferrin, which causes an increase in your TIBC. If you have a newborn, you're thinking of a Meckel's diverticulum as your cause. If you have a child, which I forgot to mention, that's between 6 months and 2 years of age, this is going to be a nutritional cause, usually milk baby, okay? If you have a child, it's going to be Meckel's, a bleeding Meckel's, just like it is in the newborn. Pregnancy, remember, lactation depletes iron, so pregnancy can cause iron deficiency anemia. Females less than 50, you're thinking menorrhagia. Males less than 50, you're thinking ulcers. Most common type of ulcers is a duodenal ulcer. And males and females over the age of 50, you're thinking colon cancer due to a bleed.